Mm. Okay. I see most of us want to remain anonymous. Oh, thank you, Dr. Joel. What a saver. So Dr. Joando is from Nairobi, joining us from Nairobi. Karibu sana. Okay. It seems we actually might not wait up for the 10 minutes. We should begin in 5 minutes. Because the trickling in is really good. Okay, so Dr. Nyokabi from Nakuru. Okay, Dr. Kitinga Nakuru. Ryan Kiambu. I'm seeing more Nairobi, Dr. Waweru. Uh-huh. Dr. Johansson, Nairobi. Dr. Saudia, Kiambu. Okay. Nairobi today seems to be the central. Karibuni nyinyi wote. Oh, we have Vihiga. Vihiga is in the building. I love that. Okay. Nyeri, yes. We're together, we're together. More people from Nyeri. Okay. More Kiambu, Makueni. Makueni, hey, that's a fast. Karibu, Dr. Susan. Trans Nzoia. Okay, at this point, this is a COGS meeting. Just national COGS. We have Kilifi. Oh, wow. I love it. And now that the chat is hot, with 2 minutes before we start in, um, our conversation today is on digital health. And I wanted to find out from the audience today, has any of us used telemedicine or electronic medical records or AI? If you have, tell us which you've used. Um, I believe we have, you know, an element of understanding in digital health, and hence the curiosity in joining this conversation today. Just wanting to understand what has been our interaction with it so far. So tell us, have you used telemedicine or the EMR or AI or all of them or any other that I haven't mentioned? Oh, West Pokot. I love it. Wow, karibu sana daktari. Personally, I have used AI. I've actually used all of them. The telemedicine, the EMR, the facility I work in. Um, we are fully digital, so there's also that. Okay, okay. So I believe this is good timing for us to start. The conversation we are having today is opportunities for health professionals in digital health in a changing healthcare landscape. Okay, so we want to explore how digital innovation is transforming healthcare delivery, creating new opportunities, and empowering health professionals to improve outcomes. And our speaker today is Dr. Ryan Nyotu. Allow me, I'm going to read his bio. So Dr. Ryan Nyotu is a clinician, policy architect, and implementation strategist sitting at the crossroad of care, data, and digital transformation in Africa. He is a senior fellow at the Center for Health, AI Research, Innovation and Implementation, and a physician architect of Kenya's National Digital Health Transformation. Okay. As the inaugural head of the Division of Digital Health at the Kenya's Ministry of Health, he spearheaded the landmark Digital Health Act, establishing the Digital Health Agency and designing the SMART PCN model, which is the national blueprint for standardized digital health deployment across all 47 counties and 10,000 health facilities across the country. As you can see, we found someone who's well qualified, for this conversation. So his work has directly shaped data-driven primary healthcare delivery over 10 million Kenyan households, extending digital solutions to 107,000 yes, 107,000 plus community health workers Dr. Nyotu holds an MPHIL in Health Innovation from the University of Cape Town with distinction, and a Bachelor of Medicine and Bachelor of Surgery and Bachelor of Science in Medical Physiology from the University of Nairobi. In recognition for his leadership and entrepreneurial impact across Africa's health innovation landscape, Dr. Nyotu was honored with the Mandela Rhodes Award, a distinction reserved for those who exemplify excellence, integrity, and a commitment to Africa's renewal. Medic Afya is an Africa-led organization dedicated to building and strengthening digital community health systems that work at scale, partnering with governments and health system leaders to ensure that digital health systems are not just launched, but sustained, trusted, and embedded within the institutions that depend on them. Without any further ado, Dr. Nyotu, karibu sana. If we can, let's just, welcome.
Thank you very much. Thank you very much, Dr. Wangari. It's a pleasure to be here today. It's a pleasure to meet all of you. So far, we are at 91. This is a very well attended, and people are excited, and that is something good. It is befitting. So again, my name is Dr. Ryan Nyotu. I hope you can hear me well, and you can see me well. My name is Dr. Ryan Nyotu. I'm a Kenyan-based scientist and innovator with a history in ICT, research, clinical practice, and finally biomedical engineering. And I currently serve as the executive director of Medic Afya, which is a digital health company focused on digitizing the level 1 aspect of healthcare across 8 countries across the continent, where we are seeing what happens when digital health is understood correctly. So it's an honor to be invited by KOGS Central Branch in this 50-year anniversary year to discuss the opportunities for health professionals in digital health. And the main thing I want to focus on is, at the end of this, one of the things that has plagued the sector of digital health across the world is the semantics. We've been called e-health. There's a time we were being referred to depending on which thematic area of implementation you're in. If you're in telemedicine, if you're in AI, if you're in M-health, that is how it used to be described. But all of it has come under one umbrella term that allows it to grow. And this is a conversation we're going to have today. In today's conversation, there are a few things I want to anchor. Before, they say the eyes only see what the mind knows. And before we even talk about opportunities, we have to learn how to see them. We have to learn how to know what is digital health exactly, because digital health is not the tool. So in this session, you'll see I will not talk a lot about the specific thematic areas, but I'll talk about what digital health itself is and how to build solutions that scale and achieve value. So we'll go through a very quick overview of the legal foundation. In innovation, one of the things you must look at and you must understand before you can start to build or even start to ideate is the knowledge that is being worked on and the mechanisms of translating that knowledge, and why every health worker should understand knowledge translation, because this is the mechanisms we live in every day. And then this will segue us into the conversation of digital health and the opportunity at the end. And then we'll have a few conversations with different people who are implementing digital health across the country. So let's just jump into it. Digital health is a pillar of UHC. This is something we say, but very rarely do we take time to understand exactly what this means. To be a pillar, you have to be very well anchored in law, for example. So when you think about the law landscape of Kenya, the Constitution of Kenya is the one which was the first one, a new constitution, which is the first one which provided the opening into the journey and the mandate that the other laws followed. The Constitution identified health as a right for everyone, and it mandated that the Cabinet Secretary for Health, or that time they used to be called ministers, and the name has changed a few times, must set up a health act. And this happened in 2017. And in 2017, there were... Yep.
Nyotu, could you put the slide, the presentation in slide mode?
Sure. Thank you. So one of the things that happened was, once the Health Act passed, the Health Act had 3 sections that touch on the conversation today. This was Section 103. Section 103 is the one which identified digital health as a service. What this means is, before you can offer a service in Kenya and be remunerated for it under health, it has to be identified as a service. So the first thing today is digital health is identified as a service by our most important law in healthcare. Section 104 then mandated that the cabinet secretary must implement what is called you must implement the Digital Health Act to govern how data will be handled and everything and all these things. And this happened in 2023. And then the Section 105 is the one which mandated the MOH to build the system, which I'll talk of next. But then there's a suite of laws which protect health data and they guide implementation. Here we have the DPA of 2019. We have the Computer Means with Cybercrimes Act, which was amended in 2024. And then we have the community health strategy, which has guided quite a lot of the work. And we have the different laws. We have the CHW bill, which is being discussed now, and also the Primary Healthcare Act, which is implemented together with the SHA Act, the Social Health Insurance Act, together the four of them, including the FIF Act, the Facility Improvement Fund Act. These ones are the ones which have anchored the UHC. So digital health is very well anchored in law. But for this conversation, we'll focus on what the MOH vision was for digital health. We were meant to implement a comprehensive, integrated digital health information system. This did not mean we implement one system, but it meant that whatever ecosystem is built, all systems must be able to participate. So in Kenya, digital health is not to be looked at as a vendor trend or donor pilots, which is how it was for the long time. It is a legal mandate as per the laws of our country. So to start with, we started asking ourselves, so what does the sector look like? So in 2018, we reviewed a lot of, together with my colleagues at my lab in UCT, we reviewed what are the different implementations that were happening in Kenya and what is the nature of the structure. So the map on the TV, on the screen, shows us how different organizations were collaborating. And this is a qualitative map. So the size of everything, the color, the shape, everything here is based on quantitative metrics assigned to the organization. The only things I want to say here is that every node or every dot you see is an organization in Kenya working within the digital health space. And every channel that you see, every black line linking them is how they link to each other and also how knowledge moves. And wherever knowledge moves, that is also where money moves. That is also how disease moves. Every linkages are also how social ties, things move within the social ties. So you can see we have a very vibrant sector. But the thing I want us to note is that the color is red and blue. The blue represents Kenyan organizations and the red represents foreign organizations. And most of them, the biggest dominant area for this was North America. And this is from 2000 to 2018. This is almost over 26 years from today. One of the things that this shows you is that this sector is generating a lot of knowledge. But where is that knowledge going? I don't think it's going to the blue. So to understand knowledge and how it moves and what it means to build solutions, you have to understand knowledge at its core. At its core, knowledge exists in two formats. The first format is explicit. Explicit knowledge is something I can tell you now and you can go and do tomorrow and you'll be able to do it properly. This is how you can read from a guideline, inject this dose and you're able to give it. Or I can tell you to go to town, climb matatu number 100 if you're in Kiambu, for example, and you'll be able to go. And this is the most dominant type of knowledge we have here. This is when you do a project together and at the end of the project, you write a report. And apart from the report, nothing else is generated from that work. This is what is called explicit knowledge. It is very easy. It's easy to share because generating it and sharing to other person is zero. The cost of copying it is almost zero. And it's abundant. And abundance is always described as the enemy of value. In terms of selling and in terms of the value you can create. Tacit knowledge, on the other hand, is a knowledge we have. It's an embodied knowledge. It is a knowledge we have by doing. If you look at how healthcare workers are trained, we go to the library and we read books, but if you read books alone and you don't go to their ward, if you don't touch the patient, if you don't understand the patient, it doesn't matter how good your theory is, the tacit knowledge comes from doing. That's why periods like internship are so important and different times like that. This is where our tacit knowledge gets to be put in. This is that thing which cannot be touched by what we write in our document. So these are the two types of knowledge. And in this conversation, what you will see is how we convert this knowledge into value is what drives the type of solutions that you have on the other side. On the other side, what the other thing that you have to understand about knowledge is knowledge in its own form is not useful. It has to spread and it has to go through mechanisms that allow it to be converted into value. And when I say value, I will be referring to the value you get by our patients getting better, the value you get by quality being improving, and the value you get by even remuneration when we work. So explicit knowledge is the one which is very dominant in Kenya. We have very many policies, we have very many things that have been generated. But one of the important findings from the 2018 work was that Kenya generates a lot of tacit knowledge, but its translation mechanisms, this is how it's changed into value. This is what lacks. A lot of that work was converted into policies, but it didn't convert into solutions. The linkage for this is that digital health is a way for us to translate the knowledge we have within us. So And how it moves is it only moves through mentorship. It only moves through close interaction with different people and hands-on work. And these are channels that we've rarely gotten an opportunity to build as a healthcare system in Kenya. And every major innovation in the history of the health industry in Kenya has been or can be described under the knowledge translation mechanism laws. And knowledge translation mechanism is basically what innovation is at the scientific or mathematical point. So every clinical economic dominance that every innovation has had has been dependent on how far can it reach into that pool of tacit knowledge that we as Kenyan healthcare workers generate. And every mechanism does three things. And I'll discuss a few of the mechanisms. The first thing it does is that it finds a way to draw out this tacit knowledge from practice. It's able to observe it and it's able to draw it out. The second thing the mechanism does, it's able to convert it into a transferable form that is ownable, that has a way to own it. And let me just pause here to explain ownership. One of the things that the Digital Health Act did that was so important was that it created ownership of data across the continent. The Kenya is one of the few countries, I think the only one. I haven't. My fellow digital health guys can tell me if there's another country that has come on board. Kenya is the one where we have ownership being anchored. When ownership of data is anchored to me, that my data belongs to me, what that is to the whole sector is that it creates an IP model. It creates a way to own it. So when the data is transferable and it's into an ownable form, this is governed by laws also. And then the third thing the translation mechanism does is to deploy it. But this sounds a bit theoretical. So let me take you through the different knowledge translation mechanisms we've had in healthcare since the start. In physiology, Prof. Patel used to tell us something called, like, based on the Sankofa. To understand an innovation, you have to go back to before the innovation was born. To understand something, go to before it was. So to understand how the hospital is a knowledge translation model, you can't look at it today and understand it. If you look at it today, you'll only see the signs of where for example, it struggles. You'll see a country where we have very many unemployed healthcare workers in the same country where we have very many overworked healthcare workers, and the model is not able to afford them. We get to hear terms like only 35, most counties are already hitting the 35% wage gap ceiling that they can't afford to employ anymore. To understand that properly, you have to look at the knowledge transfer mechanism and go back to before. Before we started, the hospital was not there forever. Back in the day, in our traditional societies, we used to have the village healthcare workers, who were later called by the colonialists. They were called the wagangas, who used to be embedded. They used to be the modern day, what they're trying to do. They used to do what the modern day CHP envisions or tries to do to today. They used to move around and just be in society. And even in the West, if you watch old movies, you'll always see when the rich people got sick, the doctor comes in with a small bag and they're able to see them at home and they're able to do this. But for something had to happen that had to bring people together. And this is what I want us to focus on. And one of the earliest things of aggregation, of doctors coming together to observe each other's practice, was during leprosy and the catacombs. And many other big diseases came in that changed the way things happened. And this was the first time where I could be here and Dr. Kigondo is next to me and I could observe him and I could see, why are you doing it that way? Why are you not doing it this way? May I do it this way because this is how my professor taught me and practice was always like this. Because of that sharing of interactions between the two of them, we were able to, for the first time ever, we were able to look at it and say, wait a minute, maybe I can do it like you, that can become a standard. When standards began to spread around many people, then financing entered. We could be able to all bill for the same service. If the patient came and we amputated their leg, we could also say we're charging at this point. This was a very critical point to understand the hospital as an innovation. This is when the hospital converted from being just a building to become a machine for translating clinical judgment. This is when it allowed us to be able to bring in our knowledge in different formats. You come in as a pediatrician, you come in as a different person, you put in your knowledge into the machine, which is the hospital. On the other side, patients get better. On the other side, you get revenue. But this is one of those models that even till today, its spread has not been very, very clear. The word round, for example, becomes a way to capture tacit knowledge into explicit knowledge. The judgment of the consultant becomes captured into something that is written down and can be repeated and replicated in different ways. However, the value of this always remained near source. The patient had to be next to me. The time I could spend with the patient is limited, and it only captured the knowledge, the lived experience of the patient and the doctor in that episode where the two of them interact. it did not extend too far beyond the walls of the hospital, and it's also very capital heavy to do. And it's also one of those things where we are still till today still discussing about helping women to deliver in facilities. This is still a metric we are counting. But this has been one of the greatest and most successful ways knowledge has been translated into practice. The second one, which was really huge, was the pharmaceutical industry. For this one, it captured the same knowledge again. That was the same knowledge that was there in the nurse, the same knowledge was there in the pharmacist, the same knowledge in the hospital, in the doctor. And this knowledge, instead of being converted into a one-on-one episodic engagement, it was converted into a codifiable molecule. This molecule then became patentable. By patenting it, it became again something you can buy and you can trade as an asset at a global level. And this is why, for example, you can see that Africa has contributed quite a bit. All of us, in any discussions you have within medicine, you'll discuss about how many drugs do we know that have been developed from discovery to full commercialization and ownership in Africa. How many pharmaceuticals in Africa have been able to do this? We have the story of the rosy periwinkle from Madagascar. We have the Hoodia of the San people, which was actually identified and patented even before the San people themselves were identified as being acknowledged as an independent community. And this one was one of the biggest ones because it showed us that translation mechanism can become spectacularly successful, that health knowledge is the valuable resource. And it's so valuable, it can become a global champion in terms of revenue generation and value changing. The pharmaceutical industry changed things in ways we did not expect. It changed its life expectancy, and if you read about it, it changed quite a few things. But it also showed us one thing, that even if a mechanism can be extremely successful, it can also be spectacularly extractive at the same time. And by this, I mean a lot of knowledge for pharma has come from Africa in terms of the root cause. But only 2% of this investment has ever made it back to today. So in coming to digital health, one thing you see about the mechanisms of knowledge translation, the difference between each and the time, each mechanism goes further to see what is this knowledge, this healthcare worker holds that I can extract and convert into a form that is better. And with every step, the distance has gone further. So into the 21st century, in the era of massive compute, in the era of the mobile phone, in the era of advances in education, the area of massive connectivity, we have digital health here with us. And because of how it's come, many of us, we are living in it without understanding how it is. And this has come from the journey of how it's been defined. The earliest definitions came from WHO. And this one's, and the one I like using a lot in my writing and different things, is a WHO one, which had the point of anchoring the nomenclature in the technology. And this is why when you say digital health, the first thing someone says back to you is AI, telemedicine, a HMI solution, and different things. And this is because it was anchored here. And the importance of this is the saying that says to name something is to dream of its future and to imagine its place in that world. So when we name something as a tool from the start, what we do is we will always measure it as a tool. But then the father of digital health, one of the neurologists from the States, his name is Eric Topol, who has written 2 books that anybody who wants to understand digital health properly and see it properly needs to read. The first book is called The Patient Will See You Now. And this is the one I'm going to refer to. What he did was he moved the focus away from the technology. He moved it to digitizing the human being. He looked at it in terms of democratizing access. For a long time, and restoring empathy. But I'll discuss this a bit. But it shifts the definition away from the technology to the person. He describes digital health as the lived experience of the human being as they move through the healthcare sector as captured as zeros and ones. So here again, it anchors it on the human being. The first final one we argue is a knowledge one, where it moves it from the tool to the patient to the knowledge that their care generates and what that knowledge can do to the sector, how it can change it, what it can produce. So the redefined definition of digital health is a continuous, ambient, real-time capture and commercialization of tacit clinical, behavioral, and experiential knowledge at the point of care and in the lived experience of populations. What this means is that it's not about how many devices we put in a facility. It's about what value these devices are able to help us achieve. It's not about the number of systems that are running, but the number of value. It is not about we've implemented a HMIS in the hospital that makes the healthcare worker sit there for 2 or 3 hours longer. It is about how can I make this interaction between the two of them become even more intimate? And this is something that Topol described. Topol described in his books, he describes AI as his vision of AI in medicine, not as something that comes to replace the healthcare worker. He describes it as that thing that comes to return the healthcare worker to having a seamless interaction with more information and more knowledge with the healthcare healthcare worker. Let me give an example here just to theorize it a bit. If you look at the knowledge, and for example, let me pick one theme: the democratization of innovations and knowledge. For a long time, in the first two mechanisms, the hospital and the pharmaceutical sector, the knowledge that has been used to generate value in the sector has always come from the people who've gone to school and the people who've experienced it. The patient, who is a very key component of this entire sector, has very rarely ever gotten a chance without having to work with a doctor or something to generate knowledge. But if you look at a lady who, for example, has gone to have let's say they've gone to have a plastic surgery procedure done in Turkey, they come back to Kenya, they experience complications, their surgeon here asks them to go to India for a procedure, they go to India, they come back, they recover in Kenya, and then they are better. That particular patient has more information about international referral networks than, for example, me, who works in a county facility in Kenya and have not been exposed to that. But yet it will be me who will sit down and decide I'm going to design an app to help patients be referred. This is not how digital health works. Digital health works by looking at whose knowledge is being converted into a mechanism that earns value. And in this situation, Africa, and this is the biggest opportunity, Africa is not the laggard in this. Africa is the frontier, because necessity is what forces a larger dream into being. For us, if you look at our population is the youngest, is amongst the youngest, and socioeconomically we earn the least, and we bear 25% of the global burden of disease. Our rates of training young doctors to become and professionals to become specialists, and even providing access to facilities and fixing our funding models so that we're able to employ many, are not matching the pace of disease. Therefore, we are in a situation where Africa needs to innovate, or we will see a lot of chaos happening to us in the next 20, maybe in the next, by 2030 to 2050, we'll be in an era where if we don't innovate and we don't understand that we need this, we will be in a situation which is very tricky. So, and this is something which you see in terms of even how the definition has been captured in the West. The West have not had really a reason to dig deep into understanding what digital health is, as much as we in the global South have to, because as I say, you can never decorate a house that was never built. So as Africa, we must discover digital health as a substitute architecture, not an augmentation. So yes, digital health will do a lot of work in increasing efficiency in service delivery, but our gaps, these gaps where we are not able to reach, that is where the opportunity is, and that is where we're able to do it. Because digital health is continuous. It is always capturing knowledge. It is not episodic like the hospital. It is ambient. It is able to, what ambient means, it's able to infer different rules from millions of decisions without the clinician having to narrate them. And then it has an unlimited surface. It means it's not bound by any wall, it's not bound by any molecular constraint, and it's not bound by geography, but it is there for every single interaction. So when you're looking at yourself as you look at the opportunity for the health professional, the AI is not here to replace you. The AI is here to validate the knowledge that you have, and to allow us to see what are the other mechanisms. Must it be that if I want to make money, I have to go and sit in a hospital and see a patient, or I have to go and sit at a screen and see a patient, or I have to go work in a lab and develop a device or develop these things? There are new models which are going to come, which today we can't even imagine. But in like in a few years, you'll start to see the second order effect. And it's important I pose, okay, let me finish that up, and then I talk about second order effects. The second one is clinical judgment. It is the clinical know-how that is going to make these solutions be the ones that work. It is not possible for me to sit down and design an app for obs-and-gyn people, for obs-and-gyn, and tell them use this app for this. And all I can do is create the tools that will allow the obs-and-gyn teams to come and build better solutions. This is why it's very important for us at this moment to be reading about what tools are available. And here, tools haven't even gotten to AI. I'm talking about the core tools. I'm talking about tools like Community Health Toolkit, which allows you to build solutions for community. Talking about Open Health Stack, which is built by Google, that allows us to be able to come and join things and be able to build them. I'm talking about tools that allow us to turn our knowledge and own it ourselves and be the ones who are introducing these solutions into the center. And then again, to be the quality owner, to be the data quality owner, to own the data and to also own its data quality, and to be able to track how this data is going, and to be the node that gives this system. The tenet of this is that clinicians, we healthcare workers, be it a CEO, be it a nurse, be it a doctor, be it whichever cadre, we are not just users of the system. We are the knowledge asset. We are the core we are the core at the center of this conversation. The important thing here, for example, for us to talk about is, think about, I was having this conversation with a friend of mine who happens to not be in the health sector. They're in ICT. And I was telling them this story, and when I was telling them this philosophy of the value, and that we can't won't be able to see the value until later. And here we're describing, for example, if you look at Kenya, one of Kenya's best implemented systems is called the e-community health information system. That at Medic we support government with its building and running and operating. One of the things you find when we have this conversation with them is we are connecting the community health promoter to the facility, and again those records back to the household in a very transient way. If you look at that as a work, you will miss the point. That is just building the infrastructure. For M-Pesa, for example, when M-Pesa started, M-Pesa was just meant to connect me and you in terms of being able to send money to you and you being able to send money to me. But once they built the road and it started working, yes, our businesses got efficient, things got better and better, different new service models came in. And when you look at the second order effect of M-Pesa today, the second order effect is much bigger than M-Pesa. The second order effect of M-Pesa is what? Back in the day, we used to, if you walked around Nairobi, you'd always see the yellow booths that have the charity sweepstake. Today, you don't see them because of M-Pesa transactional value. The betting industry has blown up to become one of the biggest sectors. If you see a recent World Cup, the only companies that could afford to advertise at the World Cup were mostly betting company. That is something that came as a second order effect of just building the highways at the ground. And then I come back to this. So here, when we looked at this thing as government, and we looked at it and we said, we have very many digital health solutions in this country. So Kenya's digital health problem was not a lack of technology. It was a lack of coordination of these technologies. Where is all this data going? Where is all this tacit knowledge going? Is all of it going to the west, the red, or how can we keep it within our borders? And this is where the government decided to put the government together with the digital health advocacy groups and the different governance structures around digital health came together and were able to say, let us build infrastructure and let the markets build the industry. So here, what I mean by the government will build the roads and the ports. This one will support trade and logistics. They'll build the power grids and the internet. But then the rest of us are the ones who are going to come in and innovate. So, and some things have been done. I will skip this slide for now. And this is the architecture that was settled upon. And this is the national infrastructure that has been built for digital health in Kenya. So what do I mean by this? If we have very many systems but they're not communicating, this is akin to if we didn't have English and Swahili as our standard languages for operating at work. We would not be able to communicate if all of us came speaking in our mother tongue or in our preferred Sheng dialects or any preferred language that we have. But unless government creates the core, it creates the road, then we come and create the industry. And this has been created, in a way where they are running the shared services. So we have the client registry. This is the one which has the unique identifier. So here, the equivalent of this is if you come to a facility, this is the one that allows me to know who you are. Traditionally, here we're moving from the card to you present your ID and you have a unique client ID, and this one marks you as you move across the entire country. We also have the healthcare worker registry. This is the one that allows us to uniquely identify a professional. This is the one that allows us to know Dr. Ryan has not paid his license, but he is seeing patients, and this is not right. We need to talk to Dr. Ryan, because if something happens, this legal case will go very badly. We need to be able to identify this facility. Is it registered? And when they say they can offer this operation, where is that document that allows them to do that? These are things that are always running in government, but to get them is sometimes usually very hard. So now the facility registry allows you to do this. We have the community health unit registry, which allows us to know where a patient comes from and where they're going back to. Who is the community health promoter and community health assistant who are working in that region to enable them to be able to offer the services. And then the terminology services. The terminology services are the standards. These are the ones that allow us to all speak one language. If you're saying paracetamol, all of us are saying paracetamol. One person is not saying Panadol, the other one is not saying PCM. And then the entire encounter is captured under a shared health record. What this allows us to do, it allows us to have, for example, community health workers moving across the country, seeing patients, That data being available at the facility level. So when the pediatrician is complaining that this mother always comes back to this facility and there's something happening in that region, why aren't they eating properly? That conversation doesn't have to end in frustration. That conversation can be a conversation between the community health promoter and the doctor, and they create a new tool, and that tool goes and has its own value, and we find a way for it to be remunerated by SHA as they solve that problem. This data then again moves to level 4, and then it can move all the way to the county national dashboards and then to the national intelligence platforms that are able to allow us to really see where exactly are these gaps and where should we be putting priorities, and where should we be putting the money. But in digital health, one thing has to always be there. One thing the pharmaceutical sector showed us is that you can build a $1 trillion industry on African knowledge, and almost none of that comes back to Kenya. And if the molecule was a codifiable form that could move that fast, data is more portable than ever, than anything else. If left to its defaults, digital health will repeat the other models. But this is something where I've described through the legal landscape, where we've been able to set the enabling environment. In Kenya, we have data sovereignty. I see a lot of uproar in social media when people say that data is being sold, this is being happening. The laws of Kenya do not allow this. It is very easy for any one of us to go and say, this should not be done, this is not to be done. It is a point of us actualizing them. We're already living in this world. The second one is we have to design solutions that are designed by us. They have to be designed by the frontline healthcare workers. They cannot be designed in offices and then brought to the frontline healthcare workers. That has been the challenge that has caused us to not have successful implementations. That is the difference between digitizing a country and digitalizing a country. In digitizing a country, we put computers in facilities and hope they work. In digitalizing a country, we put computers in a facility and ensure that they are used to provide benefit to the source of the people there. The clinical and economic value has to flow back to the workers, to the workers. So as we think about different opportunities, and as we go into this conversation of different technologies being implemented locally, the one thing I always tell clients who come to the digital health clinic, understand what your baseline is. Simple conversations. What EMR is running at your facility? What core is being used? What data flows in and out? You cannot say you want to be involved in digital health, yet you don't understand the digital health you're already in. Because as I say, digital health is a pillar, and the other pillars are human resources for healthcare. If you remove human resources from healthcare, from any sector, that sector collapses. There's no obs-and-gyn without the healthcare workers. There's no pediatrics without the healthcare workers. The same thing happens with health financing. And the same thing also happens with the other pillar, which is the health products and technology. If you remove the drugs, remove the devices, we're not able to do this. Digital health is a pillar. Until that point, you can see how it being removed will cause the sector to collapse. That is where we'll start saying now we're starting to see exactly what digital health is. So it's something we live in, but we rarely ever identify that we are living in it. I have been doing an assessment of the implementation of the app for the last 3 years. And one of the significant findings I found is I'll ask my fellow colleagues in the sector, has the Digital Health Act affected you in any way? And someone will tell you, no, I haven't really felt its effects. It hasn't touched me. And then I'll ask them, so describe for me how the process of submitting a claim has changed your day-to-day practice. And someone will tell you stories and stories, yet not understanding that the process of the claim flowing, all that is anchored under digital health. All that is digital health. But these are the things we cannot be able to identify the opportunities we are not able to see. So the thing I do is the 3 steps is identify one clinical workflow, choose one decision data that you would want to improve. One idea you would see, if I were able to do this, I could improve the value of my patients, I could generate this type of income, and start thinking about it. And then we will, in the future series, we'll discuss how to build solutions, how to anchor solutions in economic models. And then also always connect with your county focal person. This is a theme I tell all the doctors and healthcare workers I meet. If you don't know the name of the CHP who is bringing clients to your facility, you must go and find out from your public health office in the facility. But in finishing, Africa has more tacit health knowledge, and it has the least infrastructure to translate it than any region on earth. This asymmetry is not a problem. This is the largest health innovation opportunity since the invention of the hospital. Imagine if you were there when they were building the biggest hospitals in Kenya. What type of hospital would you have built? We are there right now. We have the chance to build the largest digital health systems this world has ever seen, and we will own them here, and the value will come back here. But we have to understand how to see it. But because sometimes I tell these stories and they seem theoretic, I have been looking through different models that are there, and I'll tell just one 5-minute story before I give it back to the host. I'll use 4 minutes. During COVID, one of the mistakes that happened during COVID globally was that we built COVID solutions based on epidemiological knowledge. And this was of course the obvious. It's like the default. If you don't set the time on your watch, it says it's on your phone, it says the time is 0000. The default for a lot of digital health solutions has always been epidemiology. Because this is what has been used for surveillance, for incidence and prevalence. This has been the thing that has been used. But COVID was a very interesting virus. COVID as a virus, COVID had an incubation period of 6 days. That meant from the time you got infected to when the symptoms started to show was 6 days. After those 6 days, it took around 2 days for the serious symptoms to come and someone to say, let me go get tested. So that was day 8. And then we had 2 more days before the turnaround time at the start of COVID, before you could get your result back. So if you build systems on epidemiology, contact tracing was beginning at day 10. However, COVID had a latency period of only 4 days. This means from the time you get infected to the time you are able to spread to other people was only 4 days. That means from day 4 to day 10, before contact tracing or any digital health app even starts to work, COVID was spreading. And this was a conversation we tried to have with very many people as we're developing apps. And this was a conversation that was landing because epidemiology was a default knowledge. We were not thinking about digital health in terms of knowledge. So a few friends of mine and in my innovation company, we decided, why don't we build and test this idea? So what we did is we built our own COVID surveillance app based off of what is called the sociology metrics. So sociology was traditionally a very qualitative area of research, but with advances in machine learning models and AI, we are now able to extract quantitative data from sociological environments. That means sociology then becomes a new way for us to do disease surveillance. That wasn't new. So we built this solution. It was a very simple mobile app that was sending messages every 3 days, asking people have symptoms, connected to a very advanced machine learning model in the back end. And we used to have a clinician working, one clinician working at a facility. So we tried the hospitals at the start of COVID. Hospitals, we had our friends, we had our own hospitals, they agreed, we were able to do the pilots, we were able to prove the tests, but we were not able to sell this idea to hospitals because, and by that time, I never thought I could sell a digital health tool to any other sector but healthcare. So then something happened as we were trying to understand the strategy. Then the government decided they're going to reopen the schools, and they gave the schools like 2-3 months to reopen schools. And then they gave them big manuals. For those of you who are parents and actually around time, you remember how stressful it was. So what we did at that time was we went to one of the schools and we told them we want to support them and we want to deploy the solution. And our solution will allow them to not be measuring temperature at the gate, we'll be capturing data, able to do these things. And we're able to deploy this thing because the social model was based on who do you talk to every day? Who is that one child in class? Who is more likely to spread to other person? Who is that one parent of that child? Who, if they get COVID, their comorbidities will cause them to be very sick. So what was built as a health solution and a digital health solution ended up having way more value in the education industry and helping private schools to open up. And by the time COVID was ending, we already had discussions with government about can you also apply this to public, but it was focused on the pay model. And the interesting thing about this was the health financing model. It cost every student in every school, it cost them only 200 shillings per month. So this was only a 600 bob increment per term for these children. Most of them were in private schools. And for that month, we could provide surveillance from the homes all the way to the facilities, all the way to the school. The school could have one nurse, and that one nurse in the morning could be able to see the entire school and their symptomatology. They could be able to offer services. If one parent at home got symptoms, the system would be able to alert this, and the nurse would actually call the parent at home and link them to care. And this thing built up. And when you imagine one school has 1,000 students, and you're making around 600 bob a term, that means per term the system is making around 600k. 600k will not allow you to run a digital solution comfortably. But when you go to 10 schools, all of a sudden per term you're making 6 million bob. When you go to 20 schools, you're making, and then the scale model for technology grows in a way that other things don't go. Your core costs remain central, but the other ones go. The point of this story is, if you understand that digital health is about to change how we offer healthcare to the country, it will map over what we already have, but will make it more efficient. But the opportunities lack when you look at your knowledge and see where is there a gap for my knowledge? Where if I am able to put it there, I'll be able to generate value to those clients, I'll be able to make money. I'll stop here. These are the references for the conversation, and we'll be able to take questions. Back to you, Doc. Though I think we should hear from my colleague. I think I'll segue into hearing about the narrative from. Let me give it back to Wangari, and then you can give Wendy. Thank you very much.
Thank you, Doc. Wow, that was quite the elaborate conversation. I think from your explanation, we can tell that you truly were a BSc physiology. You really went into the root. You just didn't deal with the symptom. You went into the etiology. Thank you. So we have Dr. Wendy Gitu also giving us insights as a digital health professional. Dr. Wendy? Dr. Gitu?
Thank you very much for the opportunity. My name is Dr. Wendy Kidu, Head of Telemedicine in Murang'a County. I'm also a digital health innovator. First of all, is to thank Dr. Nyotu for such a deep and rich presentation that we've had from you, and for creating a good foundation on what digital health is all about. So mine is just to give a few insights and maybe comment on what you've maybe talked about on the experience we've had as Murang'a County. I would like to say that in Murang'a County, we do run a telemedicine program that is basically for patients living with non-communicable diseases. And I'm happy that you've talked about knowledge transitioning into solutions that really solve the issues that we are facing in Kenya that are local for our patients. So Murang'a County started its digitization way back in 2023. That is when we had all our facilities digitized. And from the data we were getting, it was very clear that the county was having a huge burden for patients living with non-communicable diseases. And the way the system used to be then, with patients majorly visiting the bigger facilities, the level 4 and maybe the level 5, for them to have their clinics for diabetic and hypertension, it wasn't working well because they used to be very congested, or patients used to have very long waiting. Maybe they would wait for 6 months or even 1 year before they were scheduled for another clinic because the patients were too many. So, and that is how we designed our telemedicine program, such that the patients living in the rural facilities would not have to travel all the way from their rural facilities to the main level 5 facility for services. We would be able to have doctors sitting in a central hub, and they would offer virtual consultations to patients who are in the rural facility. And this really improved the access of care for our patients, because currently in our program we have around 23,000 patients. And on a day-to-day basis, we are able to see 450 patients per day. And that translates to around 7,000 patients per month. So you can imagine all these patients previously would not have had the time, or they would have taken a long time for them to seek care. So digital solutions are really one helping us improve on the access of care for our patients, especially those in the rural setup, because we know very well the distribution of even professionals is mostly maybe in urban towns or urban centers, and this disadvantages the patients who are living in the rural facilities. So, and another thing, we also know that in our country, the health workforce is also very limited. So a solution like telemedicine enables a doctor seated at the hub to see many patients from different areas without the doctor having to go to the patient in the rural facility. I love that you've talked about that we should be able to develop solutions that are fitting our rural setup. And I'll give an example with the internet connectivity in Kenya. We all know quite well that connectivity is majorly in the urban areas, and it's now spreading into maybe the rural areas. And most of the patients might not have maybe the smartphones that they can be able to have a virtual consultation with the doctor, or they might be the elderly who might not know the know-how of how to operate a smartphone. So creating solutions that are able to fit our patients becomes a key thing as we look at the solutions that we want to offer in our healthcare delivery system. So for our Murang'a County program, what we normally do is we have these patients visit their nearest dispensary, because at the dispensary we are sure we are able to have power 24/7. That if we are not on KPLC, at least we have a backup generator or we're on solar. And we've also ensured that there is 24-hour internet in that facility, such that it is very easy for the patient to just go in, have a virtual consultation with their doctor. If there are any readings that needs to be done, like maybe a blood pressure reading or a sugar reading, it's done there. And we are able to distribute the medications that they use to that facility such that they'll go home with their medication. So that has really worked for us because it fits the kind of a population that we are serving. And on opportunities that come with digital health, there are very many. It's a good opportunity for us as professionals now because technology is here with us, and we have to find ways in which we also adapt to it because it's not going to change. So adapting to things like maybe having professional think on maybe doing teleconsultations rather than the usual clinics that we have. Have people maybe who look at data, do data analytics. That is also another opportunity. So from me, from where I sit, I would say that digital health is really improving on the healthcare service delivery that we have in our country. And it would be better if we continue adopting some of these digital solutions that are around. We will be able to reduce congestions in bigger hospitals. We will be able to refer patients in the right time. We will be able to ensure that diseases that are chronic, like diabetes and hypertension, patients are continuously followed up, and that improves their outcomes. Thank you very much. Back to you.
Thank you, Dr. Gitu. And I believe Murang'a County is quite the template on, utilization of digital health. Thank you for that. So I see 2 hands up, and I've also been taking notes of the questions. So we can start with Ayub Robert. Ayub, are you able to unmute?
Yes, I am.
Okay.
Can you hear me?
Yes, we can hear you.
First, I would like to thank Dr. Nyotu for such an elaborate and spot-on presentation, capturing the transformation that is happening in Kenya, specifically the health sector. My name is Ayub Robert. I'm the CEO and founder of Amicus Wellness Flags, a company that connects high-risk pregnant mothers to finance and care in real time through the use of AI. I think there's a lot of opportunities, and I would like to know your thoughts on two things. The first one is the current architecture and transformation happening in the health sector is largely curative, but there is an opportunity of preventative care extended to doctors, and that is a slot of revenue generation for doctors. Because when you look at the slot for consultation, a specialist, when you restrict your knowledge, especially when you're talking about knowledge transfer and making value out of this, the knowledge sits with the doctor. What we are doing at Amicus is partnering with doctors, where doctors get chatbots, and that knowledge is documented, put in a pipeline that it can be audited and transformed in a situation where you can build your own pool of patients and they can learn and interact with you continuously, connecting you with the CHP. My question is this: are there any slots of connecting to the digital health infrastructure with regards to one, the knowledge directly to the patients, and then two, financing? Because through the same doctor's chatbots and in partnership with community health promoters, a doctor's chatbot can actually connect a high-risk patient in the local community to a donor in Nairobi. those are two gaps that can actually plug in into the national digital health infrastructure. Are there plans, or that is really far-fetched? Thank you very much.
Thank you, Ayub. I think I'd also allow the other hand up so that Dr. Nyotu can answer. Oh, actually, there are more hands up now. Job Nyamino.
Maybe Wangari, before even Job comes in, maybe Job can answer the question on the opportunities to connect the digital superhighway as he asked his question, so that we move the questions along.
Yeah.
Yeah, so thanks a lot, and good evening, everyone. My name is Dr. Job Nyameino. I lead the digital health team at Safaricom. One, I want to thank Dr. Ryan for a great presentation that really went into the, do I want to say philosophy of digital health or the concepts of digital health, and not, the technology, because health is an information business and the technology is just an enabler. But from Dr. Ryan's presentations, he gave us the why of digital health and not the what, which I think is a very good starting point. And as digital health professionals, he said it's a pillar of health or the health system or UHC. And I feel like such webinars, such presentations will help bring awareness to the wider medical community on what digital health is and its importance. And I'm sure subsequent webinars will now go into the details. So to answer Dr. Ayub's question, yes, there is an opportunity. So the digital health superhighway, quote unquote, that Dr. Ryan showed, and that the government is working on, we're supporting as Safaricom, is just that. It's a superhighway. Anyone, you can have your car, and as long as you have your license, you can drive on the roads. So it's not limited to the curative. It's an enabling infrastructure that will support information flow across the health ecosystem, if implemented to the way we envisioned it. And so from a wellness perspective, a preventive perspective, a curative perspective, you can connect any system that is using the standards that allow you to connect, and it can allow you to basically send that information across that infrastructure. So it's something that will take, it's a big topic that will probably need a separate webinar. But yes, you can connect from any platform. Thank you. So mine was a comment, Ryan, not a question. Back to you, Dr. Wangari.
Thank you for the remark. Thank you, Job. So I can still see the hand, Daniel, but there are also some questions that I had seen from the chat. Dr. Ryan, I'll just read them, then you can answer all of them. So there is one that says, to develop and use AI, does one need high energy for big servers? Is that one? Then what's the difference between digital health, HMIS versus AI? I feel like we talk about them, but to just be good to hear. Now that today we're going deep into definition and just the why. Then for digital consultations, do you call them for physical examinations if needed, and how do you go about it? And then how are telemed consults and remote patient monitoring services structured around SHA to prevent low provider payout and also prevent fraudulent digital claims? Dr. Nyotu, I hope you are noting them down and seeing that there's only one question left. Daniel Kanyata, you may ask your question.
Oh, thank you. Thank you for having me. Thank you, Dr. Ryan, for that brilliant presentation. I'm currently practicing surgeon in Nairobi, and I've realized in our market the big determinant in in healthcare is transaction costs. So you are currently in competition with an informal, unwritten sort of referral network of brokers and word of mouth between patients. Oh, I had this good surgery from this patient. So there's an information asymmetry. Do you think that your digital health reduces transaction costs to a point where it puts out the informal market out of business? Because I've not seen it. I still get referrals from patients, patient word of mouth. Still get referrals from brokers. So I don't know. At what point will digital health probably have lower transaction costs than what is happening now?
Okay. Thank you very much for those questions. There's some which I'll go through first. There are some I'll throw to Dr. Wendy, and the ones on telemedicine and consultation and physical exam. Wendy, I hope you can be able to help me answer that one, and then I can answer the other three. Let me begin with the one which is the most direct. Thank you for asking about AI, EMRs, digital health. What are they? That is a very important question. It's a question which is based on, like now in academia, some of the areas where we are really active on. Back in the day, because if you think about the oldest digital health solution implemented in the world was telemedicine, 1960s. So for a long time, the whole sector was called telemedicine. And then came the HIV era and paper funding, where the biggest thing they did for the care of the HIV patients was implementation of the health information system. So that guided also a lot of the funding from the 2000s till very recently. And in those times, the most dominant area, the one that was most funded, got called the name. But after some time, after discourse and after coming together and solidifying it, the entire sector is called digital health. Those other things are now called thematic areas of implementation. So AI is one thematic area of implementation in digital health. EMRs are one thematic area of implementation in digital health. And there are more that are going to come in the future. Wearables, where your watch that is able to track your data, that is still a thematic area of implementation. So digital health is an umbrella term. The others are the different thematic areas of implementation, or the different types of tools you can use as you're designing for care. With regard to AI, does one need huge energy and huge servers? The answer to that question is yes. AI is very heavy. One of the new businesses that are going to appear as we adopt more and more AI will be people who are going to be called AI compute landlords. So you won't have to buy it yourself, but I won't tell you to start there at that as a limiting conversation. Start at the start of what do you want to build and why does this solution you want to build require large AI. The conversation doesn't go from large to the solution, it goes the opposite direction. Start at the problem, and that will segue me into Dr. Kanyata's question of will digital health one day come and lower the transaction costs? Yes. The one thing I can say without a shadow of a doubt is yes. But that's not how we build digital health solutions. Digital health solutions are built using principles of design thinking. And the first two steps of this is always to ask yourself, the first two steps of design thinking are empathy and problem definition. So here, if I was building a solution for referrals, I would sit with the patients, I would sit with the doctors, I would sit with everyone involved, and I would try to understand what exactly is the problem. And if I find the problem is that the referral cost is too high, then I will have to put in some knowledge from health economics to help me define and design that particular bit of that solution. So it won't be a solution will miraculously come and lower the transaction. That function has to be designed into the solution. I want to give it to Wendy to just handle the questions on telemedicine. Thank you, Wangari, for the opportunity.
Thank you so much, Doc. So I see someone asked on whether the payments is under SHA. So our services are in level 2s and 3. So we get to claim from the primary healthcare fund. So any consultation done or any services offered at that level, we usually do our SHA claims under the primary healthcare fund. On whether we do it on 24 hours, no. Currently, we are only operating during the day because that is when our dispensaries and the health centers most are open. However, due to the success that we've seen now, we want to go a step further and offer our services for 24 hours. So that is something we will be doing in the next few weeks. There was also a question on, I think, who examines or how we examine. So the fact that our patients are going into a facility, there'll be either be a nurse or a clinical officer who will be guiding the patient. So in case of maybe any clarification that the doctor may need, those two come in handy. However, if it's a complicated case, then that is where we now refer to see a doctor physically. Thank you. I hope I've answered your questions.
Thank you very much. Maybe I can just ride on that and just point out that the more of us who come and engage in telemedicine, for example, right now, SHA is redoing their benefit package. If, for example, we had very many telemedicine solutions which were here, this would be a conversation we would go as the advocacy group and say, please put a bigger allowance for us. But it is one of those things, the more we use, the easier it gets for us to be able to do advocacy with the technocrats who are designing the health financing models. So this is a big opportunity, and I'm very happy to hear from Wendy about the PHC. Wangari, thank you very much. I'm giving it back to you.
Okay. Thank you for answering the questions. I think there are two more. I'll have to take this one as the last one also because of time. Also, just to let everyone know that this is a series, so we will have a part 2 of this. So don't worry, if you're not able to answer all questions today, we'll be able to answer in the subsequent meetings. But Dr. Nyotu, on the cost aspect of digital health, especially the one SHA uses in a country like Kenya, where getting medicine is difficult, does digital health put unnecessary cost on healthcare system? Is there value for money? And then, are we really there in terms of national literacy level, in terms of government preparedness, in terms of percentage of healthcare workers familiar with the available tools, in terms of familiarization on the part of our clients, which is the patients, and how prepared are we as a nation in all aspects of digitization before we start yearning for specialization in digital health? A question from Simon. Dr.
Okay.
Wendy, Dr. Nyotu.
Question: is digital health an unnecessary strain on the sector? This has been one of the questions that we have met over the last 20 years as we've tried to implement digital health at scale. If you look at the main reasons why digital health was not implemented at scale, they used to say lack of political will. And then they used to say competition for resources with other things. And for a long time, it was an either-or conversation. And here I'll say we've moved away from this type of discourse. Before you do anything, for example, before you do any project of this scale, one of the first things you must do are investment cases. For example, before we went to digitize community health promoters, the area for the governance for community is called the community. It's called the CHU for UHC, the Community Health Unit aimed at getting us to UHC. We were able to help government working together with the World Bank and different people who really focus on the economics of digital health. And we're able to do the investment case. And what the investment case showed is for every shilling or for every dollar that's invested in the community program in terms of helping prevention, what the sector was getting back was $16 back. So this means if I invest a million shillings, I'm going to get back in terms of saved costs back to the healthcare sector in how we calculate them. In terms of DALIs and the other things and other aspects, we are getting back around 16 million. This is a very huge investment. This is where the cost of digital health sits. It doesn't sit as an additional cost, it sits as a cost saving. So digital health, if you look at the cost of digital health as, oh, it's so expensive, what you're doing is focusing on the cost of building the road. You're not looking at when you build this road, how many economies are able to be unleashed. And that is how, when you're approaching a conversation of digital health economics, you should always start from that view. From Simon, I like the question from Simon. Are we prepared as a country? No, we are not. But does that mean we don't start? Again, no, it doesn't. Actually, the best times to start doing something is when you're most unprepared. For it. Why do I say this? And this is why, for example, you see that we are very keen on what government does. Why the DHA and the laws are very clear on what the government does. The government is going to come and build the infrastructure. The government is going to come and build the core things that me and you can't do on our own. Me and you can't come and set up a cybersecurity pipeline protecting data from hackers, which is health data. That will be too expensive and expense to put on my small individual company. That is something only government can do. The government is the only one which can create the sovereign cloud. The government is the only one which can create the health information exchange. So what is the role of the rest of us? For example, what KOGS is doing today, KOGS has noticed the gap within the sector that the healthcare workers are unprepared for this. So what is KOGS doing? KOGS is putting this as a series to be able to do it. There is a part where we have to take ownership of digital health, because digital health is an opportunity for all of us. If we wait for government to do it and then when it's ready we jump into it, we shall have missed the boat. The data will have gone to the West and will be again an extractive economy. Thank you very much.
Dr. Nyotu, there was a question by Daniel on surgeons and the. Did you address it? I think that's the last one.
Already.
Okay. Thank you, everyone. This has been truly an amazing conversation. We've learned so much. Dr. Nyotu, thank you. Dr. Gitu, thank you. I'd like to shout out to everyone who's able to join in. A special shout out to our World Medical Association President, Dr. Jacqueline Kitulu. Thank you for joining in the conversation. Yes, she's been listening in. And would also want to shout out Dr. Diana Marion. She is the head of provider relations at SHA. We've seen the questions about SHA. Dr. Marion, do you have a comment?
Thank you, Wangari. Good conversations. I think Nyotu has really done good service to the conversation. We are looking forward to hearing more from the various presentations that are yet to come. And thank you for providing this opportunity.
Thank you so much. Again, thank you for joining in. Thank you for the questions, for listening in. This has truly been amazing. As I mentioned earlier, this is going to be a series. Look out for the poster. In 2 weeks, we'll have a part 2 of this. And yeah, let's learn more about digital health, and so that we are also, this is the opportunities there in Santini Sana, and have a good night.
Thank you very much, Wangari. Been an amazing host.
Thanks, Nyotu. Excellent job, Wangari.
Oh, yes, Dr. Kigondu.
Presentations. Thank you very much. See you guys.
Kwaherini.